Hello. So, we're going to continue to talk about the obstructive sleep apnea. As we talked about in the introduction and then subsequent one as to who should be getting a sleep study, the signs, the symptoms, the Epworth scores, the neck size, the body mass index, and many other stuff. This time I'm going to talk about the types of sleep studies that can be done. I did mention in my last one about just checking the nighttime oxygen, which is a very simplest and the cheapest one of the tests done at your own home by putting a clip or a finger sensor. Some of these oxygen check machines come as a wristwatch type of device where you can put it on your hand. The wire extends to the finger where you can put your finger into it and it records the oxygen. But that is a simpler way. All that it tells you is that your oxygen has dropped during the night for a certain length of time. It does not diagnose the sleep apnea, nor does it approve getting any treatment for it. So in this one, I'm going to talk about the actual sleep studies and maybe about the various options of treatment. So the actual sleep studies are more than one variety. Simple way to understand would be one variety where you have to go to a lab where they hook you to various monitors. Other one is that you can do it at home. And third one that you can do it at home but also has a brainwave recording equipment given to you. So let's talk about the simplest way and who should get it. So those people who have no comorbidity. What does it mean? That means people who don't have complex health situation or health problems like high blood pressure, diabetes, heart problems, irregular heartbeats, congestive heart failure. They can certainly do a home sleep study. The home sleep studies are done with a simple device where there is a 4-channel recorder. It records the airflow, nose and mouth, single belt to know the chest wall movement, oxygen check, pulse. So based on the 4-channel recording, if the airflow is not recorded at the nose or the mouth and the chest is moving, that is considered an obstructive apnea. If the airflow is reduced and the chest continues to move, that's called obstructive hypopnea or less breathing. If there is no airflow at the nose and the chest wall movement is not recognized, it's called central apneas. If the airflow is reduced and there is no movement, it would be considered as central hypopneas. So basically, the definitions are same except that there is no brainwave recording, there is no eye movement recording, there is no wrist or the muscle tone, there is no buccinator or any other leads that could tell you anything about the person. So essentially, it is a recording of the respiration and the airflow. In addition to that, there is a pulse and an oxygen recorder. Since there is no brainwave recording, we truly do not know if patient slept, patient did not sleep due to the equipment. And if the recordings are not correct, you could lose the data and could reduce the incidence of hypopneas or apneas. I often give this example, which I think I gave it to you before also. If in the home sleep recording of this type, there are 40 incidences and total recording is for 8 hours. 40 divided by 8 would become 5. So this is apnea hypopnea index of 5, which is borderline. But think about it. If even though the recording was for 8 hours, person actually slept only for 4 hours, then 40 divided by 4 would be 10. So actually patient obviously has sleep apnea. So my statement would be home sleep recording underestimates severity of apneas or severity of obstructive sleep apneas. So the second modified method came in picture, which is where they have not the multiple leads that are done in the labs, but at least some recording to diagnose the sleep or the sleep onset and waking, etc. So additional leads are added to record the brain waves. Again, the rest of the leads are same. Airflow at nose and mouth, chest wall movement, pulse and oxygen. And again, the definition is the same. This is much better. The only problem with this particular one is that we have to depend on the patient to put the brainwave recorders, number one. Number two, it is more expensive than the first one. And number three, if false recording is done, you have spent more money. Most of the leads, as we call it, for recording the brainwave and the others are disposable. These leads are expensive. So the cost of doing a study goes up. It does add to at least knowing if somebody slept or not, but it does not eliminate the errors that could occur if the equipment is not properly attached because it is done by the patient. So this is the second type of sleep studies which are done at home. Better than first one, but not as good as the one in the lab. Again, if there are no coexisting conditions, certainly we could try doing home sleep recording. The third kind of recording is where actually you go to a lab. The technician takes the history, you fill out the sleep papers, and then you are attached to several monitors. Many of the labs create atmosphere as if like you are in a bedroom with a nightstand, TV, bed. And what it does is that you have multiple other leads. So there is a chest wall lead or thorax, belly movement, oxygen, EKG, actual EKG, airflow, nose and mouth, eye movement, because eye movement is important to diagnose REM sleep, the buccinator or chewing muscle recorder, then restless leg syndrome diagnosis is considered, so you have that lead. And in addition to that, there are several leads to record the brainwave. So you actually can see wakefulness versus when the sleep occurred, when patient was in stage 1 sleep, which is very light sleep, stage 2 sleep, slow wave sleep, which is supposed to be the deepest sleep, and the REM sleep, which is very active sleep when people dream. The reason is that in REM sleep, people have highest amount of apneas. It also records the position, as supine position has higher number of periods of apneas and hypopneas compared to lying on one or another side. So because now we know exactly when the sleep occurred, we know exactly what sleep of the sleep stage you were in, how long was the REM sleep, what was your position, how much was your oxygen dropped, and whether it was apnea, hypopnea, and also the central varieties. This is much more detailed and it is much more diagnostic. The problem with this is it is more expensive. The tech has to be there. And in addition to that, some people will not be in position to do good night's sleep with all these leads attached, as well as in an unusual, uncommon room surrounding with a technician watching through a one's view glass mirror. But this is the gold standard for diagnosing sleep apnea. We'll talk about some of the treatments of sleep apnea in my next video. Thank you for watching. If you like, subscribe. Thank you. Have a nice weekend.